Welcome everyone to this week's installment of AMSSM's National Fellows Online Lecture Series. My name is Matt Wise. I'm an assistant professor in family medicine and orthopedics at UT Southwestern. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on rhabdomyolysis, which will be given by Dr. Nate Nye 1 week from today at the same time. For tonight, I'm very excited to welcome Dr. David Bernhardt to speak to us on an introduction to the pre-participation physical evaluation and some unique clearance considerations. Dr. Bernhardt graduated medical school from the University of Wisconsin and then completed his pediatrics residency and sports medicine fellowship, all at the University of Wisconsin. He is now a professor there in pediatrics and orthopedics, serving as the program director for the sports medicine fellowship and team physician for the University of Wisconsin. Previously, he has served on AMSSM's board of directors and the American Academy of Pediatrics Council on Sports Medicine and Fitness. Originally published in 1992, he is co-editor of the Pre-Participation Physical Evaluation Monograph, a document supported by multiple professional societies, including AMSSM, which is now in its 5th edition. Before we get started, we'd also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members and at times invite guest experts, and ultimately to assist in CAQ exam preparation. And some reminders to please mute your device's microphone and turn off your video. Submit questions through the chat function. As the moderator, I'll be monitoring that throughout the talk, and we'll ask questions during the Q&A at the end of the session. And then lastly, please complete the evaluation at the end of the lecture. One of our new efforts is to facilitate some more input from our audience. There are a couple of ways to do this. First, a web link can be found by going to amsssm.org. We want to click the Education tab and then select Fellow Online Lecture Series. The link is near the top of the page as seen in the screenshot here. Second is by scanning this QR code. It should take you directly to the form to fill out. And when filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. And so now, without further ado, welcome Dr. Bernhardt.
Thank you, Matt. Let me make sure I'm sharing my slides. Everything just moved. Does that look okay?
That looks great.
Okay, so welcome everybody. The picture behind me is our Union Terrace. It's a beautiful night here in Madison, and if I wasn't giving this talk, I'd definitely consider going down there. It's a great place on the water to have a beer, listen to live music, and totally relax at the end of the week. For those of you who may be looking for fellowships and have not gotten that far, please give us a look. A little self-plug there. So thank you for joining us. I have changed the title of the talk a little bit, and the reason I did that is, as Matt mentioned, I am one of the co-editors for these pre-participation evaluation monograph. And I really feel like all the nuts and bolts of the pre-participation monograph have not changed much since the first edition. There's been little tweaks here and there that have improved the process from my perspective, but overall, how we do it, when we do it, why we do it have remained the same. And rather than talk about challenging cases that you can look up, I'd rather on a Wednesday night, make you guys think about how would you design this pre-participation evaluation if you could start from scratch and not have the monograph to lead the way. So try and be open-minded as we go through the slides tonight. Think about discussion topics at the end, and feel free to put those in the chat, and Matt can moderate. And Matt, feel free to interrupt me if there's something compelling that we want to talk about as we go through. And otherwise, we'll address those discussion questions at the end. And at the end, if people want to unmute and ask, that's fine as well if people don't want to put it in the chat. So with that said, the talk tonight is going to be, what if we could start from scratch? I really have no conflicts other than what I mentioned as the co-editor, and I will emphasize for sure that there was no financial reward for being the co-editor of the monograph. It is a large commitment in terms of time and effort for all of the writers that are on there. And Matt mentioned that there are writers from lots of different organizations that were represented, AMSSM being one of them. And it was published by the American Academy of Pediatrics, mainly because they already have a publishing arm that made it easy to do. But everybody contributed. And Bill Roberts from the University of Minnesota, who's now retired, was the other co-editor with me. There will be a 6th edition of the monograph coming out, hopefully in the next 1.5 to 2 years at the latest, as I know the writing group has convened and I'm not participating in that group. So with the Olympics going on, I think how you would think about taking care of a patient or a student or an athlete like Noah Lyles or Katie Ledecky is probably completely different than the group that we're talking about. And although they are athletes just like anybody else, and they put their pants on one leg at a time, genetically, they are both blessed in terms of being superstar athletes. And in terms of what we would do in terms of clearance for the pre-participation evaluation is probably fairly similar to what we would do if they were a high school athlete. On the other hand, they are being sponsored by professional organizations. They're really professional athletes, even though you might think of the Olympics as amateur. They may request other tests to be done, and they have the money to back that up in terms of lab testing, EKG, echo, VO2 max. And so what you do for somebody like that from a pre-participation standpoint may be completely different. Noah Lyles has been, it's actually been written about fairly well in terms of some of the other things that are associated with his success that may impede him to getting to be that successful, and thinking that he's made it that far despite some challenges related to things like ADD, learning disabilities, depression, anxiety. He's made it as far as he has, probably has a lot to do with not only his genetic talents, but a lot of the support that he had on the way or along the way. In terms of thinking about the pre-participation evaluation and thinking about how we all agree that it should be done in the office, think about what might happen if you were working like Matt does in Texas, and you're asked because of access issues to go do a pre-participation evaluation in the 90s in a small city in Texas. And this is the athlete that you are asked to do the pre-participation evaluation on. And instead of doing it in the office, you do it at the kid's school as a favor so that this kid can participate in sport because you heard he's pretty good and he's down on his luck, and you go to the school and you do the physical and you sign the form and you go on your way. We're going to come back to this athlete later in the talk, but think about what you might have missed when you do it that way. Think about, is that really appropriate way to practice medicine? And when we get to the end, you'll see why I'm highlighting this case, because I worry that we all get asked to do this on a regular basis, whether we do a mass participation type of physical at a high school, whether we do a one-off and go over to the school and sign off on a kid in the training room. Doing it in the school situation may not be ideal. So this is the framework that I want you to think about as we go through the talk tonight. In terms of learning objectives, I want everybody to leave here thinking that the pre-participation evaluation should be part of comprehensive medical care for everybody when they come into your office. I also want you to remember that mental health screening and screening for social determinants of health may be more important than getting an EKG or an echo, or possibly even doing some of the other parts of the pre-participation history form that we highlight on the second half of the history form after question 13, and I'll show you the history form later. But looking at mental health screening and social determinants of health in terms of bang for your buck is going to go a long way compared to the rare kid that you're going to pick up with a heart abnormality. And the third thing is, I think people complain all the time about the pre-participation evaluation and how much time you have to spend with the patient and all the things that you're supposed to go through when you're doing comprehensive medical care, and you just don't have enough time. And that's why using a standardized history form is so important, so that you can spend most of the time addressing all of the other issues that are important, and recognize that the pre-participation part of things may not be that important at all, compared to all the other things that we think about in terms of sex, drugs, and rock and roll. So when you're thinking about athletes and who's coming into your office, and when I say you should be doing a pre-participation for all, what do all the following people have in common? These kids playing outside at recess, the high school varsity cross-country runner, a University of Wisconsin swimmer, or Deion Sanders' son playing quarterback for the University of Colorado, a Paralympic level downhill skier, or just an adaptive skier not competing in the Paralympics, somebody who's competing professionally and winning the Stanley Cup, recreational road runners participating in the Boston Marathon, or an older person like me doing weights or standing outside jumping rope. I would argue that all of the people that we just showed should be considered athletes, just like anybody else who comes into your clinic. And I think we all complain at times about some of the patients that we're seeing in clinic and how sedentary they are and how they are not exercising regularly. And I think it's our goal to say that everyone who comes into our clinic, our goal is, if ACSM's theme of exercise is medicine, all of these people should be considered athletes, and we should be promoting exercise, but we need to make sure that it's safe for them to exercise. So when you think about the pre-participation purpose versus the comprehensive medical purpose, that's highlighted in these two circles. So on the left is your typical comprehensive medical visit, whether it's pediatric or adult, where the person comes in for a well visit or a health supervision visit, however you want to call it in your clinic. So you do some disease screening, you review their medications. For the child and adolescent, you probably are going to look at growth and development. You're going to promote wellness, including exercise as medicine, and you're going to provide some anticipatory guidance related to things like birth control, alcohol, drugs, nutrition, supplements, anabolic steroids, anything else you want to put in that umbrella of anticipatory guidance, some of which might be included in a pre-participation evaluation. On the right, in the yellow circle, are what we think the goals would be for any of the monographs that have been written: promoting safe participation, preventing sudden cardiac death, assessing injury risk and, quote, preventing injury, and meeting liability standards. And when you look at the evidence on how well does the pre-participation evaluation do in addressing those four goals, I think the evidence is lacking, other than the last goal, which is meeting liability standards. I think we can promote safe participation, but that doesn't necessarily mean that the athletes are going to practice or compete in that manner. We can try and reduce the risk of sudden cardiac death, but we may not prevent it. We can assess injury risk, but I don't think there's anything we are going to do in that office visit that's going to necessarily prevent injury. We can reduce the risk of injury potentially by recommending some proprioception and strengthening exercises, but I don't think we can prevent it. So really the only thing we're doing from a monograph goal, evidence-based, concrete, black and white, is meeting liability standards for the national organization that's requiring that person to have that piece of paper signed that says you've examined them and it's safe for them to practice and compete in sports. When you're thinking about these people coming into your office for their pre-participation evaluation, keep in mind that for most of the, especially adolescent student athletes and the college student athletes, that pre-participation evaluation is likely going to be their only contact with a medical provider. And if they were not coming in for that reason, many families do not bring their kids into a clinic situation unless their kid is sick or they need something. Therefore, when you have them in for this one touch, take advantage of it and make sure that you spend just as much time on the left circle as you do the right circle. And there is some, like I said, intersection where there is going to be overlap. I hope that makes sense to everybody. So now going on to the parts of the pre-participation evaluation that I think for sure this part of it is lacking in the pre-participation monograph. And that is the social determinants of health. Where do these student athletes that are coming in to your clinic, especially at the high school level and sometimes at the college level, although now with NIL, it may not be as dramatic, but where do these people live? And what is their social situation? And what's the environment? Do they have a roof over their heads or are they homeless? Do they have food insecurity? We have programs right here in Madison, Wisconsin, which many people think is a fairly well-off community, where the high schools have to provide sandwiches before games, like peanut butter sandwiches. The parents get together and provide peanut butter sandwiches as the pregame meal because so many kids on the team don't have access to food. What is the education level in terms of the athletes and families that are coming in? And what are the barriers in terms of them even getting health care? Next week, I'm doing pre-participation evaluation in the way I don't like doing it, where I am doing mass physicals for kids in our community who either have problems getting access, they can't get an appointment soon enough, or they don't have health insurance and the money to pay for a pre-participation evaluation. So think about how this pre-participation evaluation requirement impacts somebody who would benefit from playing sports competitively, and they don't have a way, either because of access or money, to get this pre-participation evaluation, and then the kid wouldn't go out for sport. All of this is highlighted, I think, very well in a Journal of Athletic Training article authored by Pika in 2022, and I encourage everybody to look at that as a reference. Just to highlight this a little bit, in the Journal of Pediatrics in 2021, a study was done looking at a huge cohort of patients who had needs in terms of some of those social determinants of health. And they are asked questions in terms of any general social need, food insecurity, housing, transportation, and utilities. And then they were asked about the urgency of addressing those conditions. And you can see that in terms of just general social needs, there is a significant percentage, 12%, that have some social need. Food insecurity, almost 6%. Transportation, where transportation has been lacking to get them to a medical appointment or from picking up medications, 5%. And people who had difficulty with their utilities being turned off for not paying the bills, 4%. In terms of are those needs urgent, when they answered that question, in some of those categories, it was almost a third. So these are real problems that our people are facing. And I don't pretend to have the answer, but it does impact healthcare, and it impacts accessibility and ability to play sport because they don't have access to get this physical done, or they don't have access in terms of transportation to get to school, or they have to work a job to provide for their family, and they can't participate for that reason. Just from a reference point, I talk about it being difficult in terms of time. We have forms to deal with the history part of the pre-participation evaluation, but the way the monograph is written in the form that we use, there's nothing about this social determinants of health. And so if you wanted to improve things going forward, one thing that I would highly recommend is having a supplemental social determinants of health questionnaire pictured like something here, where the families would fill it out, every family, not just those that you try and determine are at risk for some reasons that you can't really put a finger on. So I really think it should be part of every visit, looking at things like housing and food and utilities and personal safety and transportation in determining how you might be able to help them. And I think if you look again at the frequency of these kind of problems compared to the risk or frequency of somebody dying suddenly, this is more of an epidemic and the other is quite rare. From a food insecurity standpoint, there's food insecurity and then there's food security, but even those that have food security and can provide food and might have food stamps to pay for it, don't always have a way of paying for the healthiest food that we have. And if they're lacking in lots of other of the healthy foods, they may be having difficulty with things like obesity and type 2 diabetes and all those other health risk factors that we often talk about. From a food insecurity standpoint in the United States and the state I live in by race and ethnicity, looking at all households in the United States, dark blue, light blue is the state of Wisconsin. You can see it's almost 15% of all households and 11% in the state of Wisconsin. And again, in terms of just what you would think from a socioeconomic standpoint, much more common in the Afro-American and Hispanic culture. Again, more for poverty reasons than necessarily their race. So what are the solutions to these kinds of problems? The solutions from a public health standpoint are going to be things like having what I talked about earlier, some type of program to provide meals for kids on game day, or breakfast and lunch programs for the kids to be able to get through the school day, or figuring out ways to get them transportation to medical appointments, or bringing the medical care to the school with some dedicated health professionals in the school. That doesn't solve the problems when the kid is in your office. That's more from a public health standpoint. For the kid in your office, it's very, very challenging. And I don't know that I have a great solution for many of these problems that are there, but I am not afraid to put consults in for the social workers or caseworkers that work in our clinics to try and help the families when we can. I want to switch gears at this point and talk about the other part of the pre-participation evaluation that we did change with the last edition. But I still think, even though we all recognize that mental health is a problem, I don't know that we spend enough time screening for it. I personally think that every kid who comes into your clinic, whether they're coming in for a true pre-participation liability signing of a form type of physical, or they're just coming in for a physical and they don't play sports, everybody should be screened for mental health concerns. So this is how we have it in terms of the PHQ-4 on the pre-participation monograph as it presently exists. And I can tell you, soon after we released and published the monograph, the #1 question that I received as an editor, both by email and colleagues that work directly with me in the office, is like, I'm using this new form, but what does this mean when we get this? And people are circling and, what is a positive score and what's a negative score? And that is all highlighted on the monograph. But if you take the top 2 questions related to anxiety or the bottom 2 questions related to depression, and the score is greater than or equal to 3, that would be a, quote, positive screening test. I personally, if somebody scores anything greater than 0, I still take the time when I'm doing the pre-participation evaluation to have at least a brief discussion about anxiety and depression and how it might be affecting them in their day-to-day life, how it might be affecting them in their sport, and ask them if they need or would like help. And again, help in the community can be challenging. So the reason I have this picture up is this is Greg Steemsma, who just got hired as a player developmental coach at the University of Wisconsin, and actually played for the University of Wisconsin well over 10 years ago. And Greg played after he left Wisconsin in Turkey professionally, and he had a short stint in the NBA with the Boston Celtics and the Minnesota Timberwolves. When he played for the Celtics, he was gracious enough to meet with a reporter from the Boston Globe and talk about his struggles with his mental health, in highlighting that it's not something that should be shunned, and it shouldn't be something that you're going to be judged about, and why he was able to get help at the University of Wisconsin. And it wasn't because we had this great form and we picked it up during the pre-participation evaluation. It was because he had bonded with the athletic trainer, a gentleman by the name of Henry Perez-Guerra, who's a friend of mine and retired about a year ago. He was able to bond with Henry and call Henry late at night one night and talk about how depressed he was. And then Henry was able to get him into our clinic to get help. Would it have helped when he was a freshman if we had been asking at that time those types of questions? I don't know, but it wouldn't have hurt to be asking those types of questions. And then the question becomes, if they answer all of it negative when they're freshmen, when should you screen them again? Because I think many of us, for the college student athletes, they might have a returning physical with their athletic trainer where they just make sure their medical history hasn't changed. But does that include re-asking those questions for many of us? And then should you just re-screen them 2 to 3 months after they started in school? So many of these kids show up in the middle of summer. It's during summer vacation. They're taking 1 summer school class or 0 summer school classes. They might be anxious about just moving to Madison. They may not have any trust in their medical care at that point. They may not want to admit they have a problem. But as they get used to you, you might want to ask those same 4 questions again to them 3 months later and check in to see how they're doing. The other group that I think we should be screening again, not only when they are coming in for their pre-participation evaluation, are the people who are injured. And we all recognize how injury can affect the athlete physically. And I think we can recognize that can affect them mentally. But I think a lot of us probably brush it off and say, this is just a natural response to be diagnosed with a bad knee injury, and the kid is going to overcome it. But if that kid remains socially isolated, is not able to rehab the injury well, then turns to other means of trying to adapt to the social isolation and depression that they have, and is never able to return to sport, we have done them no service by trying to re-screen them for mental health disorders as they go through the injury process. So what next? You find out that somebody's answered these questions positively, or you find out that with time, the athletes trust you and bring it to your attention later, or you screen positive after an injury. What do we do next? And I would argue that what you do next is take more history, just like you do for anybody else, okay? So again, this is the highlight. A sum of greater than or equal to 3 is considered positive on either subscale when looking at these questions. And it merits more attention. So what does merit more attention means? It means that you might want to explore all of these other issues. Maybe not when you're doing the pre-participation evaluation, especially if you're doing it in a station-based format or seeing the kid at school, but you may want to bring them back to your office and talk to them about all the things that can go along with depression or anxiety, and recognize that a lot of these kids have other comorbidities related to sexuality or gender issues, being abused sexually or physically as a youngster, being injured, having a problem with disordered eating, fatigue, sleep, comorbid conditions, and then they may have all these other social determinants of health problems that only contribute and heighten their mental health problems. So don't forget about addressing that as well, because they often go together. If you're looking for a more detailed sport-specific screening, you can also use a mental health tool developed by the IOC that is very well done. And I think rather than considering that a screening, I think of it as more of an assessment tool. And I don't think we have time to go over it in detail, but if you're looking for a true assessment tool that you might want to use to assess a group of people's mental health after they've gone through your screening, I think this would make sense. And it talks about a lot of the same things, but just in a lot more detail. And it also talks about how their mental health affects their athletic participation. So it's much more athlete specific. All right, now, the other part that I think is important that we talk about regularly, that you will hear at many AMSSM lectures, is how to reduce the risk or prevent sudden death. And there are families that are very worried about that when they come into your office. And as people age, like me, we also worry about having heart conditions. And I think for those of you who practice adult medicine, hopefully some of these same questions are being asked of you so that you can be triaged appropriately in terms of possible further testing. So questions 4 through 13 are really the most important cardiac questions on the entire history form. And when you're looking at the history form, if people were to try and get rid of how big a scope this history form is, I would argue that you could just go through the 4 mental health questions and questions 4 through 13 and probably shorten the time the patient is in your office, especially if they have not filled out the whole form ahead of time. So when I see patients in my clinic and I'm pressed for time, and just because I work at a university doesn't mean they give me an hour for each patient. I have 30 minutes and somebody has to room them and get their vitals and fill out, the medical assistant has to do their part of their history form or history taking. Then they have to have time to give the vaccines at the end. So in general, you're getting, if you're lucky, 15 to 20 minutes with that patient. I don't want to waste all my time having them fill out a form in front of me that they forgot to fill out. So I'll usually say, you know what, I'll do some of my social history on my own, and I'll just make sure they fill out these questions 4 through 13. So in terms of cardiac screening, there's cardiac screening in America, and then there's cardiac screening in Europe. So cardiac screening in Europe, there's an article that was just published in the European Heart Journal last year, where they did heart screening like they are required to do in Italy for every kid participating in organized sports between 7 and 18 years of age. They have medically trained sports physicians that they are required to do this physical. It's not like, hey, go see the nurse practitioner or the PA or the primary care doctor or the orthopedic surgeon who's not held a stethoscope in his hand since he finished residency, or the chiropractor, or anything else that's allowed in your state. So I'm not trying to say that a chiropractor or a PA or an NP is any different than a primary care provider or some of the other doctors. I think you want to see somebody who knows how to take care of student athletes and does primary care on a regular basis. I would argue that an orthopedic surgeon or a urologist or a neurosurgeon does not do primary care and should not be doing these. And I would also argue that chiropractors probably don't have the same training. But in Italy, they have trained sports medicine doctors that are required to do these for all of these kids. All of these kids not only go through the routine history like we do, they get an EKG and they have to do submaximal stress testing. And anybody who has a positive history, a positive family history, an abnormal physical exam, an abnormal EKG, or if they fail the submaximal stress test, they get to go through further cardiac testing, including cardiac MRI and maximum stress testing. So that is what I would call a Mercedes-Benz or Cadillac cardiac screening. So how does this compare to what we do, and is it worthwhile? And there are people within AMSSM who would argue that everybody should get an EKG, and we can talk about that at the end if you want. But how does it do in this test? So these kids are getting this done every year, as long as they're playing competitive sports. So there were 22,000 athletes, consecutive athletes that were screened, median age 12, who went through all of these tests. These were repeated every year. And on average, because some of the kids dropped out and the study time was a 10-year study period, that it was about 3 times per young athlete that was tested. So of all of these people, 69 were eventually found to have some congenital heart problem, channelopathy, cardiomyopathy, scarring, or arrhythmia. Okay? So they found 69 people, or 0.3%, who had a cardiac condition. They then looked at how many of these people total had a cardiac arrest, and there was 1 case. So all of these people who were found to have a problem that would be at risk for sudden death, as we'll go over, I think, in the next slide, are then deemed ineligible for competitive sports unless they are cleared by a cardiologist after going through adequate treatment. But if their condition doesn't change and they're at risk, the law in Italy says that they are unable to continue participating. It's not like they have shared decision-making for these kids, and some of them can play and some of them can't. They then do allow them to go through a tailored leisure exercise program if they are medically disqualified. And I do think, importantly, just like anybody else that we would find in our country, they provide psychological support. What does this cost per diagnosis of heart disease? 92, I looked at what it cost in pounds in the article, and then I converted their pounds to dollars. It's 92,000 American dollars in this study per diagnosis of heart disease. So think about that, and then think about this. In terms of what do we recommend on our American screening, we want to find out, are the symptoms associated with exercise? Are there other associated symptoms? Should they go through, or have they gone through a previous cardiac evaluation? And are there other variables that might explain their symptoms? And how many times have you been in clinic sometime during your residency, for those of you who are fellows, where the athlete has said, you know what, it was just a really hot day, or I really was exerting myself as hard as I could, it's never happened since, or I didn't eat lunch that day. So they have already a bias in terms of why that happened to them. And how many of you say, yep, it was a hot day, and you just sign the form and you don't ask more questions? So I do think it's important that you don't just say that the athlete is telling me it was a hot day or a diet. They don't have any medical background. They want to be cleared. Their purpose of going in to see you is to get cleared. Their purpose is not to have to go through an EKG, an echo, and a cardiac MRI before they're ultimately cleared. And, you know, based on sometimes accessibility, they don't get those tests done for 2 months. They want to be cleared today in your office. So make sure that you're asking the right questions. And if there's any concern, have a plan in terms of what you're going to do to try and get them that care as soon as they can. In terms of what I really want to highlight with the Italian way of doing things and the way we do it, or the model where they do demand EKGs, when you look at the sudden cardiac death rate in Italy overall and some other studies that have been published compared to what we do in America, the sudden cardiac death rate from sport participation, when you look at the big population, is the same. And what you need to ask is, for the rare athlete who is picked up on their screening, that rare person, their outcome might change, but it might not. Not everybody who has hypertrophic cardiomyopathy is going to die. Not everybody who has an anomalous coronary artery is going to die. And in the past, we didn't, like when I trained as a fellow, there was really no risk stratification or shared decision-making. It was sort of like the Italians, where they say, you're just not playing sports. And so things have changed a lot since then, and there's going to be a lot of nuance that you will learn during your fellowship. And you want to work with people who can have honest conversations with the athlete in terms of what their risk is, but be open to the ideas that maybe there's a way to mitigate risk with a defibrillator, or maybe there's a surgical treatment, or maybe there's another genetic test that might make their outcome more predictable. But it's not black and white in terms of what that outcome is going to be. And you need to keep that in mind. Just because you diagnose them with a cardiac condition doesn't mean that you're going to ultimately change their outcome. So you have to think about, there are going to be athletes that you pick up as positive on a screen who may have continued to be asymptomatic. In other words, you may be in a program where everybody gets an EKG. The person is completely asymptomatic. You pick up somebody with an abnormal EKG, you do an echo or a cardiac MRI, and they have hypertrophic cardiomyopathy, and you disqualify them from participating in sport, and they would have been asymptomatic their entire life. Have you done them a favor? And then what about the athlete who is symptomatic but would not have suffered a life-altering event related to their condition? So now I hope I have you thinking one way. And we go back to the guy in the lead here, Ryan Shea, on this picture. So Ryan, several years ago, was able to qualify for the US national team in the 10K, and then attempted to qualify for the US marathon team running in the New York City Marathon. That was the Olympic qualifier that year. And Ryan had a known heart condition where he had at least been evaluated multiple times at Notre Dame, where he ran in college. And reading between the lines and looking at his case, I don't have any personal knowledge of what he ultimately had, but he died at mile 5 of that Olympic qualifier in the marathon with a known heart condition. As an adult, he chose that he wanted to continue running. Is it up to us to say that you can't continue to do that? If you're an oncologist and somebody says, I don't want treatment, and this is how I want to go out, we don't really argue with them. But for some reason, in the paternalistic world we live in related to sports, I think sometimes we are potentially making decisions for these athletes, and they know what the risks are, yet they want to continue to participate. And I think we need to educate and go through shared decision-making and respect, especially for the adults, the decisions that they make, especially when the liability is on them and the liability may not be on us. Now, if it's a college student athlete, it may be completely different because I think the school or the university may share some of that liability. And so you may not clear them because of the school liability issue. But if that kid then is disqualified from participating, let's say I have a kid at the University of Wisconsin who has a heart condition, and I say, we are not going to clear you to participate at the University of Wisconsin, and that kid wants to go play pickup basketball at the park, there's nothing I can do for that. And if he dies suddenly doing that, that's on him. Is that different than Ryan Shea running in that qualifier? I don't know. All right, so that's the sudden cardiac death prevention part of the talk. I just want to highlight that there's really nothing that you are going to likely be able to do to prevent an injury like Paige Buchers from the University of Connecticut if she tears her ACL again. She's probably had her surgery. You've talked to her about risk. She's done all the rehab. And if she tears it again, she tears it again. And there are people who have undergone 2 or 3 of these operations, or 2 operations on one knee and 1 operation on the other, multiple ankle sprains. I think it's important to talk about proprioceptive exercises. It's important to know that those can reduce your risk of injury, but it does not prevent injury. And so if the stated goal in the monograph is to prevent injury, I don't think we're doing the population a service if that's what we educate them that we're doing. We are potentially reducing the risk, but not preventing. If you're again going to spend time on things that can reduce injury risk, there has been a study published in 2017 with the article cited here, looking at sleep hygiene and nutrition and significant injury reduction risk in those patients who are getting adequate sleep and those that are eating healthier than those who are not. So if you're trying to reduce injury, it may not be beneficial to do a detailed orthopedic physical exam on every body part and say that they are, quote, normal, there's nothing to worry about. You may want to spend your time not doing the orthopedic physical unless there's a true injured body part, and spend your time talking about adequate sleep hygiene and getting healthy nutrition. I think there are questions on the pre-participation evaluation related to head injury that are important. And I think, again, if somebody checks the box yes, that means that you have to then spend time talking to them about, are they still having symptoms related to their head injury, and review with them in detail what those symptoms might be. The things that we talk about here are just prolonged headache and memory problems, but these people may have slow processing speed, learning disabilities, memory issues, reaction time issues, and you're not going to be able to go into all of that in detail sometimes, especially if those answers keep coming up yes. If they've recovered completely and been participating in sport, it might be a very quick discussion. But if you don't ask and then you don't spend the time for positive answers, getting a more detailed history, you haven't done that athlete any service. So for those that have problems, again, you may not have time during that office visit. You may need to bring them back And in a mass participation type of physical exam, or a physical exam that's being done in the school as a favor, it's probably important to have them follow up in a typical clinic situation, if at all possible, to protect yourself from a liability issue, if nothing else. So in summary, hopefully I've highlighted the importance of overall health screening for athletes that are coming in for the PPE, as this is the only contact they might have with a medical provider. When it is the only contact with a medical professional, it does serve as a huge opportunity to evaluate other risk factors using something like the Guideline for Adolescent Preventive Services questionnaire, or Bright Futures questionnaire, or taking the time to talk about risk factors related to sex and drugs and family planning and all the other things that we talk about when we're taking care of high-risk age groups, including the college student athletes. I do also want to make sure that we emphasize that you should be looking more at social determinants of health and mental health screening, not only for our athletes, but non-athletes. And this is probably more important than the actual pre-participation form that we are using related to the traditional goals that we used to look at when I started as a fellow. Again, the pre-participation evaluation should not be used only for sports physical. The pre-participation evaluation has minimal effect on morbidity and mortality related to sport participation. Therefore, spend your time doing what I talked about in terms of looking at social determinants of health and mental health. There are very, very few athletes that are ultimately going to be disqualified. And when you get to that point, make sure that you have some individualized, shared decision-making based on the specific condition, what that risk is for that specific athlete, and the sport that they're participating in. I would also highlight that there are so many research opportunities related to the pre-participation evaluation, just looking at the questionnaire in general, and what questions are more sensitive and specific, and what can be done away with and what can't. And what other tests should be done? Should everybody be really getting an EKG or an echo or a cardiac MRI, depending on the answers to those questions? So whether the kid is a recreational snowboarder, a high school athlete, a college athlete, a recreational athlete participating in adaptive sports, a Paralympian competing at an elite level, a professional athlete, everybody is an athlete that comes into your clinic, and you want to spend the time making sure it's safe for them to participate. In terms of how this might change your practice, I would encourage you to all integrate the pre-participation evaluation into standard health supervision visits in the medical home. That should be your takeaway message today. Consider how the social situation, mental health, and pre-participation evaluation requirements may impact and sometimes even limit opportunities for sport participation. Try and use that standardized form to provide uniform assessment tools for the people coming into your clinic. And consider bias when looking at the PPE. Not only the efficacy of the tests that are done, the number of lives saved, the cost of doing this, and the reason for doing any test, and ask yourself, is doing this pre-participation evaluation really worthwhile as it stands alone by itself on that piece of paper? So remember that high jumper that we had at the beginning in Texas, and you're asked to go see him in his office, or I'm sorry, see him in his school? Well, that guy in that picture was Donald Driver, and although I'm probably dating myself, he was an all-pro wide receiver for the Green Bay Packers. He went on to play college football at Elkhorn State, and he was at one time homeless and using drugs regularly. And probably being homeless and using drugs regularly had difficulty with all the things we talked about related to social determinants of health. How did he change his life? It's not because he had an athletic trainer that he bonded with, as far as what I've read about. It's not because he saw his team physician. And who knows what his care was like in terms of his overall health in Texas at that time when he had a lot of things stacked against him. It's because he had a supportive girlfriend who told him that he needed to clean up his act or she was going to leave him. That's what made us change his life, and he got himself dedicated to football. So hopefully everybody who's down on their luck in this way has somebody supportive that will make a difference in their life. And in some situations, that's going to be you as the fellow, and someday as the sports medicine doctor for the teams that you're taking care of. And don't miss those opportunities because you're just signing off on a piece of paper and you're in a rush to get these kids in and out of your training room. There are the haves and the have-nots in our community. In our community alone, there are fitness centers and clinics, or a fitness center owned by a physician who can talk about getting the people altitude chambers to sleep in, get them vitamin drips, nutritional supplements, $250 running shoes that make them run fast, and therapy with antioxidants and IV fluids. Okay? And there's other people in the same community who need to have peanut butter sandwiches made to play a high school football game. I think we need to be looking out for everybody in our job as sports medicine physicians. And it's your opportunity, because of the one-touch rule, when they come see you for the pre-participation exam, that you can make a difference in looking at some of these things. That's all I got for tonight. Thank you for your time, and I'm happy to answer any of the questions on the chat.
All right. Thanks for that excellent talk, Dr. Bernhardt. I think you emphasized some really good points as far as social determinants of health and some things that we don't often think about when it comes to the pre-participation evaluation, as well as highlighting some kind of high yield topics like the cardiac screening, concussions, things like that. I think we've got time for a couple questions here. And the first one, I loved how you brought up the dichotomy between social determinants of health being barriers to access to healthcare for the PPE, but also that there's this requirement of the PPE to participate in the benefits of sports, right? And so we all know it's hard to see a primary care doctor, and yet these patients need the form to participate. This often results in mass physicals, right? Potentially even in like a school gymnasium, there's really not even much privacy. And so how do you advocate for these principles of screening for things like social determinants of health, mental health, things like shared decision-making, the follow-up questions that you brought up for these positive screening things in a suboptimal PPE environment like that?
That is the million-dollar question that I struggle with all the time. And I get, I'm doing these mass physicals. Last year we had 70 student athletes, high school age, come through the door between 6 o'clock and 10:30 on a weeknight. Mm-hmm. And I have residents who are doing the physical part. I have med students doing the vitals. The only thing that, from a consolation standpoint for me, is we have an immunization registry in the state of Wisconsin, so we can see who needs vaccines. And we have public health nurses and school nurses to at least update their vaccines. I know that in many of these situations that are done in the mass physical school situation, they don't even have that available. So I would encourage, if you're going to do it, to, from a public health standpoint, at least have somebody there that can give vaccinations and update their vaccines. Otherwise, I think I've had kids that I've picked up with mental health. I have tried to then set up either a separate time, or some of these kids have a primary care provider, they just can't get in. So I will have a way, find out who their primary care provider is, and then send a message to the primary care provider to say, hey, Susie came through mass physicals last night, screened positive for depression and/or anxiety. I spent time with them at the sign-out table, getting a little more information, but not a lot. So you want to have your sign-out table be in an area where you can ask some confidential questions. And then I usually say, would it be okay if I call your primary care provider and get help? And most of the time they answer yes, affirmative, that they would like me to talk to their primary care provider. What happens after that, I don't know. This is truly being done as a favor to let the kids participate. Get the physical done so they can participate. But after that, I really think it's up to the patient and the primary care provider to then reestablish care and feel like you've done your job in terms of making sure they have the opportunity to play sports. I don't know if I answered that well enough for you, but that's philosophically how I rationalize it in my head.
Yeah, and I think in the primary care setting, I think one of our greatest tools is the follow-up visit, right? And that's really how screening should be done, right? Is like if things pop up, then you need follow-up, and the tough thing in the mass setting is that it doesn't facilitate a lot of that. And so I totally agree. I think it's tough, but any little bit that you can do to kind of progress that care along, I think it is probably going to be worthwhile for sure. Kind of second question here. So it's not uncommon, like we just talked about, for athletes to come into either their medical home, ideally, or training room, or like these mass physical situations, needing clearance, either literally on the first day of practice or the day before, right? And I find that, at least in my experience, patients are coming in and they're like, kind of like what you referenced earlier, they're coming in and their whole goal is just get cleared so they can play, right? And they kind of, at least either verbally or from physical language, are essentially telling us, hey, like, you better not hold me back because I got practice this afternoon, right? If something does come up, say, there's a high enough blood pressure where you're like, hey, we really need to look into this. Say you hear a cardiac murmur for the first time, these types of things, still having concussion symptoms, even maybe, hasn't totally rehabbed a certain injury, and you need to either hold them back for a period of time, or at least you need more time to work up a positive on the screening. How do you navigate the athlete who's like, what are you talking about? We're going to the locker room in an hour.
Yeah, so I try and prep them. So like when I do this coming Monday night, the athletes, it's first come, first serve. The athletes can start showing up at 6. There's usually a waiting room full of people. I usually go out to the waiting room and say, hey, I'm Dr. Bernhardt. You guys are here for a pre-participation evaluation. This is and it's going to be done differently than it is in your office. I don't know any of you truly as patients. I appreciate the honesty that you are hopefully going to use when you fill out this form. If there is any question where I feel like I can't clear you tonight, unfortunately, that's going to mean that you can't practice, but I'm wanting to do this to make sure that when you do go participate, it's going to be as safe as possible. And because I don't know you, I have to lean towards being conservative in terms of clearance. And if they have parents there, I think the parents get it. The college student athletes that are done with the university now, they just show up sporadically, and the coaches completely understand that there is going to be a kid that comes through that their EKG is abnormal, and we're going to need to get further testing. I am fortunate at the University of Wisconsin, where we have a system set up for these student athletes that we can usually figure things out within 3 or 4 days tops. This isn't like 3 or 4 months to get an echo. When we were doing cardiac MRIs more with the COVID myocarditis scare, it was a bit more of a hassle. But in terms of where we're at now, back to our old system, it works pretty darn well. And so I have a dedicated cardiologist that reads all of the EKGs. We have a very good relationship with the cardiology department in terms of getting easy access for those that need a follow-up echo. And so that part works pretty well. It's the high school kids that I think are the trouble spots for me, and probably for many of us on the call, where I call it sports medicine's #1 emergency. So this is truly a sports medicine emergency, is getting your pre-participation evaluation done so you can participate in sports yesterday, because they forgot. And then you're stuck.
Yeah.
And you're going to find something where it just doesn't make sense to clear them, and you have to educate them as why.
Right.
And I've done this in the past. When I first started, we had a little road show when my fellowship director he took us to a small town north of Madison, about an hour away. And there was a kid who was achondroplastic dwarfism. And they have problems with cervical instability like the Down syndrome kids do. And he obviously had this genetic condition. And at the sign-out table, I was the fellow, and the attending was sitting next to me, Dr. Landry. And I said to the kid, I was like, I don't have your medical record here, but we think you may have this genetic condition. And the parents were like, oh yeah, we know he has that. And I said, so what does your geneticist say about you participating in sport? Oh, they don't think we should, but we thought you might have a different opinion. That's exactly what they said to me.
Oh man.
So, you know, they didn't tell the truth in terms of identifying on the history that the kid had any problem related to that. You don't have the medical record available in a small town. It's not, back then, it wasn't an electronic medical record. And it's all because I had the wherewithal to say that it looks like you might have a problem, and then them admitting that they had a problem. But if they go to a place where, you know, what we talked about before, where you have some of these medical providers who don't understand this and are just going to sign things off for their neighbor kid, their liability going to have big problems if something happens to that kid.
Oh, totally. I mean, it gets at your question at the start of the talk, which is when you were talking about the Green Bay Packer athlete as a high schooler. What may you have missed in the training room? That's
Right.
exactly it. And it's because you don't have the medical chart in front of you, and it's not done in the medical home.
And you're not going to take the time if
Yeah.
you're in a hurry.
No, and the system's not set up that way in terms of the mass physicals. I mean, we're doing that, you know, tomorrow night at a local high school who their physicals were canceled in the spring. So it's certainly not it's not a perfect setup, and we're working against, you know, healthcare system structural things as well as non-medical structural barriers, like you mentioned, with the social determinants of health. But I think, you know, it's talks like these that allow us to identify some of these problems, and that's the next step in terms of addressing them. So that kind of brings us to the hour mark. We really appreciate the talk, Dr. Bernhardt, and thank you everyone for participating. We'll see you guys next week. Thank you to AMSSM and the fellowship and education committees for their support.
Thank you for moderating, Matt. Have a great night, everybody.